everyone, and I also want to thank the organizers for inviting us to present the development of our pediatric global child health elective. We're really happy to do this. I think I don't need to tell the audience this again, but I'll do it quickly. Interest in global health experiences is at an all-time high among medical trainees. In fact, the AAMC reports that graduated medical students in the United States and Canada who participated in a global health experience is up from 6% in 1985 to 30% in 2009. And as such, medical schools around the country are attempting to incorporate some form of global health teaching into their curricula. Especially when we talk about residents, these curricula are mostly for short-term experiences because residency training places stipulations on the amount of time that residents can be away from their home institution. There have been concerns raised that short-term international medical trips can be self-serving, ineffective, and unsustainable. For those of you who have hosted medical students in your home institution or residence, you know that this takes a lot of time and effort and resources. And in a resource-limited setting, this can be fairly significant. Secondly, the level of autonomy afforded to medical trainees in low-resource settings isn't always appropriate to their level of training. In fact, in some settings, the standards of care being delivered won't meet the standards being delivered in the United States, and there are instances when the standards of care don't even meet local standards. Nonetheless, these experiences have an undeniable benefits to the participants, with improved knowledge of tropical diseases, improved physical examination skills from practicing in an environment where advancing ancillary services aren't available, a deeper appreciation of issues related to public health, professionalism, cultural sensitivity, and expanding of the worldview. And finally, participation in these kinds of experiences, as we've heard today, fosters interest in caring for underserved populations, whether domestically or globally. Therefore, we set out at the University of Washington to develop such a rotation for our residents. Our goal was to develop a global child health rotation to equip both United States and Kenyan pediatric residents with relevant knowledge and experience to reduce health disparities among children in resource-limited settings. After 2 years of planning and support from Seattle Children's Hospital, the University of Washington, and numerous partners in Kenya, who I'll acknowledge in a moment, we developed a curriculum after establishment of an advisory council consisting of faculty and trainees who had participated in such experiences. Our objectives and aims were established in collaboration with our partners in Kenya. The guiding principles for development of this rotation were that of service, education, teamwork, sustainability, collaboration, with mutual benefits for all stakeholders involved. And I'll tell you about those now. Our overall curricular goals were to prepare residents for future careers as advocates for underserved populations, both globally and domestically. We specifically chose to focus on social, economic, environmental, and political influences on child health and health disparities, and specifically chose not to focus on clinical management of medical conditions in facilities. The hospital was certainly interested in us attracting applicants who were going to be poised to make contributions to global health and community pediatrics in the future, and in fact this was a major selling point for gaining their financial support. We felt the best way to do this was to catalyze interactions between residents and community groups, public and global health leaders, policymakers, and child advocates to provide that inspiration for taking the next step in their careers. Finally, we hope that this rotation would provide a structure for those residents to maintain their passion for working in low-resource settings. We are seeing so many medical students coming into residency with a passion and inspiration to do good, to serve the underserved, and our goal was to maintain that during the residency. This is the structure of the residency alternative curriculum at the University of Washington. We have 33 residents per year, and we select 8 residents per year into our alternative curricula, 4 of whom are in a community pediatrics and advocacy pathway, which focuses on primarily domestic issues, and 4 are in the global health pathway, which focuses on international issues. Nonetheless, the curricula for the 2 are very similar and parallel. In fact, the first month of the curricula, which occurs in the second year of residency, is intentionally combined. All 8 residents sit together in Seattle and go through a curriculum which focuses on health systems, health economics, social justice, ethics, advocacy for health, media training, and grant writing. They engage in problem-based learning sessions, and they developed an individualized learning contract which guides the remainder of their curriculum. In the third year of residency, the final year of residency, there's an intensive care intensive block, which lasts 8 weeks and takes place in Kenya for the global health residents. Before describing the pathway in detail, I want to tell you what I think are the most unique features of our elective. First, we pair a resident from the University of Washington with a resident of the University of Nairobi for the entire 8-week experience. And they go out into the community and work together side by side. Second, the focus of the rotation is on the health needs of the community and doing a community-based health assessment, not on care of patients in the hospital, as I mentioned before. The setting for the rotation is in western Kenya, in Nyanza province. There's a town here that doesn't even make the map called Kisii. It's a rural hub which has a provincial hospital. And even by Kenyan standards, this is a medically underserved region and fairly rural. You can see it's a fair ways away from Nairobi, and we transport both residents out there together, and they stay there for the majority of their rotation. This is what the rotation looks like. The first week is spent in Nairobi, focusing primarily on preparation and orientation to the experience. They meet with faculty from the University of Nairobi and the Kenya Medical Research Institute to develop their plans. They visit various levels of the healthcare system in Nairobi together. Kenyatta National Hospital is a regional referral hospital, the National Referral Hospital, and the teaching hospital for the University of Nairobi. Gertrude's Children's Hospital is a private children's hospital with pediatric subspecialists and all the things that come with a private hospital. And they visit a variety of clinics as well, including a slum clinic, which is a very eye-opening experience, as you can imagine, for all of them. Weeks 2 through 6 are spent doing their field work in the community, in Kisii. The hospital really provides the context, the window into the diseases affecting the population, but they spend the minority of their time in the hospital. Finally, they come back to Nairobi to wrap up their experience, present their findings to the University of Nairobi faculty, residents, the Kenya Medical Research Institute faculty, and begin to debrief the experience. I mentioned this community focus, and what are the key pillars of the community focus? Well, first, we begin by asking residents to engage in identifying and tracking children who need communities and family support for their illness. This is pretty much everyone who comes to the hospital in Kisii. And in fact, there are structured home visits that the resident pairs go through together and go visit families after their discharge, the children are discharged from the hospital. They engage in developing and implementing educational activities for families and for community health workers. For example, we've developed a focus on community management and prevention of malnutrition. And so much of the training is focused on training community health workers on diagnosis of malnutrition and treatment of malnutrition in the community, and on teaching families about establishing kitchen gardens. They develop a community child health activity as well. The first pair focused on malnutrition-related mortality in the hospital. The second pair assisted local public health officials in developing a baseline assessment of malnutrition in the community. Finally, a key pillar is effective advocacy. They spend their time meeting with local political and NGO leaders, learning about what they do, and learning about their perceived priorities. They meet with traditional healers, and actually the pair there now just attended a herbalist workshop. They collaborate with administrative hospital personnel and Ministry of Health personnel as well. They're very busy when they're there. The pairing of the residents was the other unique feature that I mentioned. They really bring complementary skills to this experience, which I think make it very rich. The University of Nairobi resident has a much deeper understanding of the healthcare system and the diseases that they're seeing than our resident could ever have, or we could ever teach them in 4 months of residency. Our residents, when we ask the University of Nairobi residents what's in it for them, why do they need to pair with our residents, they say that the curriculum that we've provided our residents with on social justice, communication for health promotion, and public health brings something to their experience that they can take forward. This really wouldn't work if there wasn't something in it for both of them. The insight into medical systems and culture is really quite neat. They get to see that through each other's eyes. They go through shared processing, and as you can see here, these have turned into lasting friendships as well. It really takes a village to pull this off. These are the collaborating institutions and just some of the people involved. The administrative, faculty, and operating funds, the support, come primarily from Seattle Children's Hospital and from the University of Nairobi. The money isn't enough. I can't stress that enough. It's the will of all these people that make it happen. And specifically the leadership at the two institutions in the departments of pediatrics, specifically Dr. Bruder Stapleton and Professor Ruth Nduwati, whose vision for this elective has made it a reality. So how have we been doing? Well, we've had 5 pairs go through the rotation so far. As I mentioned, we've begun to establish a focus on community-based prevention and management of malnutrition as a longitudinal goal, with each pair of residents handing off their work to the next set as they come. We've, from an academic standpoint, been successful in that we've had 4 separate resident presentations accepted at international meetings, both in Kenya and in the United States, and our operating funds allow for us to be able to send both residents to respective meetings when their presentations are accepted. Beyond these results, I want to share with you some of the quotes from the residents. So this is a quote from a University of Washington resident. The multidisciplinary approach was key, with the intersection of ethics, legal rights, responsibilities, public health, and cross-cultural work. I was excited by the discussions that we had. We really fed off each other, and the peer-to-peer interaction really increased the value of each session. Here's a quote from the University of Nairobi resident who's now decided to pursue public health for her career. The program has changed the way I envision my role as a physician by actually giving me the tools and skills I need in order to take that next step and make a difference. So the residents are really having a good time. We really hope to keep this going for years to come and have an impact on the health of the community. And I hope that I can report some of those findings to you in a future meeting. Thank you.